Aspirants, the debriefing session is taken by Dr. Monalisha Mishra. Thank you,
Yeah.
ma'am, for being with us. You can start.
I would like you all to answer these questions. Then only it becomes interactive. So please unmute yourselves and try to answer as much as possible. So the first question is: a 70-year-old man is presenting with rapidly developing ascending weakness following an episode of gastroenteritis. He's also referred to critical care with increase in dyspnea, tachypnea. Clinical examination confirms that he has bilateral lower limb and upper limb weakness and diminished reflexes. His CSF analysis is showing this. White cells number is 2, red cells number is 8, and plasma to glucose ratio is 68. So, all of you, any of you can answer this. What data do you think is missing in this lab study?
CSF protein,
Okay, good. So, what is the diagnosis here?
possibly Guillain-Barré syndrome.
Okay, what makes us think that it is Guillain-Barré syndrome?
Uh, Preceding history of gastroenteritis with ascending paralysis.
Okay, what are the most
Uh,
common organisms? So I'll just ask you a few more questions which can be possibly asked if you get a case of AIDP. What are the possible organisms involved?
Clostridium jejuni,
Yeah, Campylobacter jejuni, right? Yeah.
Campylobacter jejuni.
Yeah. So Anup, the slide is not visible because I've already discussed the case. Now I'm asking you questions. So kindly unmute and answer some of the questions.
Yeah, okay, madam. Okay.
Yeah. Okay. So you want to listen to see the case again?
No, ma'am. No, okay, ma'am.
Yeah. Okay. So now what is the treatment of GBS?
IV immunoglobulins or plasma exchange.
Okay. So first tell me like what data was missing? You said proteins. So what do you expect in a CSF? Anybody else can answer?
Yeah, albuminocytological differentiation, ma'am.
Very good. So albuminocytological dissociation. What is that supposed to mean?
Uh, the cell will be normal, but the protein will be elevated.
Very good. So the cells are normal, but proteins is elevated. And one very important question they ask you in this is, do you see these CSF changes on the day one itself?
No, ma'am. It will be actually absent in the following first week, ma'am.
Very good. So it is usually not like seen in day one itself. It is usually seen after like maybe after day 5 if you do the CSF. Very good. Okay. So someone else can answer this. Among IVIG and plasma exchange, which is the preferred modality of treatment? Do studies prefer one over the other?
No, ma'am. Actually, both are equally effective, ma'am.
Okay. So everybody agrees with that. Both are equally effective.
In
Yes.
myasthenia
Yeah.
gravis, actually, the plex will be more effective than IVIG.
Is there a study quoting that?
No idea, ma'am.
I don't think I've come across something like that. But if you have, you can share it with everyone also. You can search right now because I think it is IVIG and plasma exchange have been found equally efficacious in all the studies.
Okay.
And that is how we should answer also. So, probably someone else can answer. Does corticosteroid have any role in GBS?
No, it doesn't have any role.
Okay, good. Okay, so that so basically you should study about GBS, myasthenia gravis, AIDP, any sort of rapidly ascending kind of paralysis. One very important question I forgot to ask: what is the indication of ICU admission of such patients? When you decide that a GBS patient who has come to ER requires ICU admission?
Impending respiratory failure, loss of inability to protect his own airway, poor breathing effort,
How do you test
autonomic
that? Any
instability.
particular test you want to do?
Rapid
Anyone?
Uh,
breathing count, ma'am.
Yeah. What is
Vital
that called?
capacity.
Yeah, so there is a 20, 30, 40 rule. Everybody can note down that. So the vital capacity and your maximum inspiratory pressure and the 20, 30, 40 rule you can tell. And you can also tell about another test, which is very simple, can be done at bedside. What is that called?
Single breath count.
Yes, single breath count. How do you do the single breath count? Anybody wants to tell apart from Anoop? Anybody wants to tell how is single breath count done?
in a single breath, the person should count up to 30.
Yeah.
If he's able to count up to 30 in a single breath, then his respiratory effort is supposed to be good.
Okay, good. Okay, any other questions about myasthenia and GBS you guys want to discuss, or it's an open forum, So we tried to discuss all the questions in the CBS that could be asked about myasthenia and GBS. But if you have any particular question or doubt in mind, this is the forum for you to discuss and get it cleared. So that you don't do a mistake in the exam. You can do a mistake here. Any doubt, anybody? Okay, so now that nobody is having any doubt, I'll move to the next question. Now my screen is visible to everyone. Is my screen visible?
Yes, ma'am.
Yes,
Yeah.
yes.
Okay. So this is the second question. A 55-year-old male patient is admitted with septic shock, was on mechanical ventilator. After initial improvement, he had an episode of fever and shock and abdominal pain. And this is the CT scan which is revealing. So please have a look and let me know what is this. Like, can you see the CT scan clearly?
Yes.
Yes. So anybody wants to tell me the diagnosis?
There is a thickened gallbladder wall with
Yes.
the distended gallbladder.
Hmm.
There is no calculus seen. Probably it is acalculous cholecystitis.
Yes, the answer is acute acalculous cholecystitis. So, what is the immediate treatment options available for this kind of patient?
Uh, Surgical gastrosurgical involvement and probable percutaneous cholecystostomy.
Okay, yeah. So you have to get a gastrosurgical consult and percutaneous colostomy. Correct. So this is basically a patient on septic shock. What are the antibiotic choices you guys have to start on this patient?
Piperacillin tazobactam.
Okay. Anything else you want to cover? Because it's an abdominal source of sepsis, clearly. So, anything else you want to cover?
We need to cover the undiagnosed.
So, my question basically comes to this, that if the patient is in septic shock, depending upon the severity of illness and the source of infection also here, how do you decide what empirical antibiotics you need to give? So obviously this is the first day in ICU, you do not have the culture reports back yet. So what is the empirical choice of antibiotic you want to start for this patient?
Gram negative and with anaerobes.
Okay,
That will
good.
be covered.
That is a good combination to start with. But how do we decide which empirical gram negative to give? So basically, my question is basically, yeah, you're right, Christina. It has to be a broad spectrum antibiotic. But what my I want to ask you here, and it's a very important question in today's world, is how do you decide? So, for instance, Tarun is working in some hospital in India. Tarun, which hospital you are from?
Local antibiogram. We should
Yeah.
follow local.
So everybody works in a different hospital, and they are coming from a different geographical area. So how do you decide which empirical? So the antibiotic choice for me will be different from Mohammed's, will different from Christina's, will be different from Vijay's. So how do we locally decide which empirical antibiotic to give a patient in septic shock? You got my
It
question?
depends. Yeah, depends on the local antimicrobial
Yes.
and local resistance trends.
Yes, so local antimicrobiogram, local pathogens is very, very important. So what basically your microbiology and your antimicrobial stewardship team in your hospital is doing is they come up with this antimicrobiogram data every 3 months, so that you know which are the local pathogens in your hospital, in your ICU, and depending on that you need to choose the empirical antibiotics, right? So any role of so what is the exact role of combination antibiotics versus monotherapy in this kind of patient who is in septic shock? So is a
If we are
combination therapy better than monotherapy?
if we are suspecting
Yes.
multi-drug resistant uh, microorganism,
Yes.
or if there has been any kind of significant immunocompromised status or recent hospitalization where he has already received antibiotics,
Yes. So if the patient is sick enough and you want to, improve the outcomes, so can someone tell me what is the mortality of septic shock, even if you do everything right? What is the percentage mortality of septic shock according to the surviving sepsis guidelines?
Every 1 hour delay, 6% in mortality.
Yeah, so basically the mortality percentage of septic shock, even if you do everything right, is 40%. So
Okay.
it is better to start an empirical dual coverage and then narrow down depending upon how the patient is responding, right? So always aim for starting an empirical dual coverage, and then you can narrow down depending on how the patient is responding. Okay. So can someone tell me what is 1 hour bundle of sepsis?
it includes collecting the blood cultures within 1 hour,
Yeah.
starting the antibiotics with the 1 hour, and
Yeah.
measuring serum lactate within 1 hour.
Okay.
And
Good.
it involves
I-
antibiotics, giving antibiotics within 1 hour. Uh,
Duct fluid resuscitation.
Fluid resuscitation.
Fluid
Fluid
resuscitation. And how
resuscitation.
much fluid resuscitation? Initial bolus according to the surviving sepsis
30
guideline?
ml per kg.
30 ml
30
per
ml
kg
per kg.
within 3 hours.
Yeah, correct. Right.
And
Okay,
if
good.
the lactate is more than 2, we have to remeasure the lactate.
Yes, good. Okay. So basically, as you said, we have to collect cultures. We have to give the first loading dose of antibiotics. We have to so we have to start with fluid resuscitation and uh, measure lactate level and remeasure lactate level to make sure that our fluid resuscitation is working. Okay, good. Let's move on to the next question. I'll start my screen sharing again. Okay, so my third question. So 61-year-old lady is admitted with septic shock, and the CT abdomen finding after initial fluid resuscitation is revealing this. What is your diagnosis?
Emphysematous
Left
pyelonephritis.
emphysematous pyelonephritis.
Everybody is agreeing with the diagnosis, emphysematous pyelonephritis. Can everybody appreciate the kidney
Left.
on one side?
Mhm.
Yes, very good.
Left.
Okay, so
Yeah.
that is the correct diagnosis, emphysematous pyelonephritis. One question I wanted to ask you here is that what are the components of 1 hour bundle you already discussed? What is the indication of corticosteroid and septic shock?
When a
If the
person is on dual
hospital is
vasopressors and there has not been any kind of improvement within 4 hours of starting the vasopressors, then we can
original
consider giving steroids.
Okay, so what is the dose of steroid you consider giving?
200 mg per day.
200 milligrams over 24 hours.
200 mg per 24 hours. Correct. One more thing I wanted to ask you is that any other role of immunomodulatory therapies apart from corticosteroids we have seen can work in septic shock? Apart
IVIG.
from apart from so this is a difficult question. Okay. So apart from corticosteroids, do you think anything else works in septic shock? Any other immunomodulatory therapy?
There is a lot of trials which has been done with regarding other immunomodulatory therapies, but none of them have proven to be beneficial, like use of cytosorb uh, and uh,
Yeah, good. So cytosorb, there are a lot of
activated protein
filters,
3.
everything, IVIG, lot of things we have actually studied which have not shown mortality benefit, apart from, I think, your corticosteroids only. So they have the only shown mortality benefit. Okay. So do you want to add hydrocortisone on single vasopressor or dual vasopressor?
Dual vasopressor.
Everybody agrees to that, or anybody has a difference of opinion in this?
Single
Yes, Dr.
vasopressor.
Ahmed Salam. There is a study for methylene blue also, that methylene blue is not an immunomodulator, but some agent which has actually shown to be effective in case of septic shock. So anybody wants to tell me the dose of methylene blue in case of septic shock?
To 3 gram per kg infusion or
So please write it down and read. I also don't remember exactly, but you know, need to know the dose of bolus and infusion over 1 hour what you're supposed to give for methylene blue. Yeah, so that is, I think, correct. 1.5 mg per kg has to be given, and then you have to start a bolus. Yeah. Okay. So apart from methylene blue, there has been one randomized control trial which has actually shown some benefit. Then, of course, there has been another this thing about, what about vitamin C? Any opinions about, does vitamin C work in septic shock? No role, correct. No role of vitamin C. You can quote a few studies also which have not shown any benefit. So, why exactly did they all think and plan a study for vitamin C? What do you think was the mechanism which was there in their mind, which they thought that vitamin C might work?
Antioxidant?
Anyone? Anyone?
Antioxidant?
Yes, antioxidant, because they thought that it will reduce the free radical induced damage. Okay, 1 second. So basically, what is they all thought that because it's an antioxidant, it can actually help us in free preventing free radical damage in sepsis and septic shock. That is why they thought that it might have some role. Okay, so then now we'll go to the next case. The 43-year-old male patient is actually having severe backache, fever, myalgia, hypotension. Shortly after arrival, this kind of rash is seen. Okay. Have a look and let me know what it is.
Purpura fulminans.
Yeah. Okay. So where do you see purpura fulminans?
In severe septic shock with infections with the Streptococcus, Klebsiella, uh,
Toxigenic strains.
Correct. So purpura
Mm.
fulminans is the correct answer. You can see this kind of thing in many things. It can also be seen in sepsis. Like in case of sepsis, sometimes there is fulminant reaction all over the skin, and this can be seen. How do you treat it?
with the a gram positive and gram negative cover with some immunomodulators like IV immunoglobulin.
Okay. So both can be used. That is correct.
Ma'am,
So
can
you
it
have to
be,
give antibiotic coverage, of course, and then you have to give IVIG. So that is usually the treatment of it.
ma'am,
Yeah.
can it be a necrotizing fasciitis actually? But it is more.
So this doesn't exactly look like necrotizing fasciitis. It looks quite different. So this is actually your purpura fulminans. And in purpura fulminans, if the causes of purpura fulminans you have to tell, you can add a few more things also. One is sepsis, of course, you said. Other than that, you can also say that sometimes in protein C deficiency, or some kind of severe infection, and when you suspect DIC and all, also purpura fulminans can be seen. So, and one more thing you all missed, I think, meningococcal infections.
Okay.
Yeah, in meningococcal infections, purpura fulminans is a severe complication of meningococcal infection occurring in 15 to 25% of such patients. So why does it occur in meningococcal infection? Anybody can tell. It is a tough question, but it's a very important concept to understand here. That why does purpura fulminans occur in meningococcal infections?
Into toxins.
Yeah. So it is basically because of DIC only. That because of meningococcemia, what actually happens is that there is acute onset of hemorrhage and necrosis together because of thrombosis and DIC happening together because of coagulopathy, and that is why it happens. So purpura fulminans, management of purpura fulminans, I think most of you told me that it is IVIG and basically treating the cause only. Okay, correct. So we'll move to the next question. A 40-year-old male patient is admitted to ICU with blisters in the right foot, which got infected. Then the patient was shifted to ICU. This revealed high grade fever, hypotension, and urine output. I would request you to take 2 minutes to actually analyze this ABG, and after 2 minutes, I'll connect to you to ask questions about this ABG. Okay. 1 second. 1 second. I'll just.
High unaided metabolic acidosis with respiratory alkalosis and hyperkalemia and hyperlactatemia.
Yeah. Tell me.
High iron gap metabolic acidosis with respiratory alkalosis with hyperlactatemia. It
And
can be seen in
hyperkalemia.
urine.
So everybody agrees with high and AN gap metabolic acidosis?
Actually, the delta ratio is little bit high, ma'am.
Yeah, but first step is finding out if it's high anion gap metabolic acidosis versus normal anion gap metabolic acidosis. After that, only we'll go to the delta and all those things, right?
Yes.
Yeah. So first it is high anion gap metabolic acidosis. And do you know what is the diagnosis?
Sepsis.
So this patient is admitted with
Septic
blisters in
shock.
the right foot which got infected. So any idea why this patient will have blisters on the right foot? Matlab anything else you're missing, which can be cause of high anion gap metabolic acidosis, can cause that kind of ABG?
Compartment
Basically,
syndrome.
the most common diagnosis which you should tell if this kind of scenario comes is diabetes. Okay, because diabetes can cause diabetic foot, that can cause that kind of blisters. Now tell me, what is the diagnosis if it is diabetes?
DK,
Diabetic
septic
ketoacidosis.
shock.
DK, correct. Very good. So DK is the correct answer here. So tell me one thing that what are the other causes of high anion metabolic acidosis you know of, high anion gap metabolic acidosis you know of? One is diabetic ketoacidosis. Anything else?
Alcohol toxicity, lactic acidosis.
Alcoholic ketoacidosis, correct?
Starvation.
Lactic acidosis.
Okay, very good. Lactic acidosis. Because of starvation, also ketoacidosis can happen. So that also we can include.
Methanol poison, uremia.
Methanol poisoning, yes. Yeah. So there is so you should know about the causes of high anion gap metabolic acidosis. So after knowing the high anion, that it is high anion gap metabolic acidosis, we can calculate the delta gap as you said. Okay, but first we need to clear the basics that we have to know that it is high anion gap metabolic acidosis. Then how do you manage a DKA patient? That is the next question.
with hydration, fixed influence, insulin infusion protocol,
Correct. Potassium
and
is necessary.
electrolyte management.
Correct. Okay, great. Yeah, so basically you have to give insulin because how does insulin work in decay?
Decreases the
Reduces the
ketosis.
ketonemia.
Yeah, so it causes ketolysis and also it decreases ketone body production. That is number one, management. Number two is, of course, fluids because these patients are extremely dehydrated and they have huge fluid deficit which you have to fulfill. At the same time, you have to manage the electrolytes. You have to, because when you give insulin, your potassium level will go down. So you have to monitor your potassium levels as well. Correct. Next question. 70-year-old, you guys are okay with the speed of things, right? Because I'm taking it slowly and I'm covering each and every topic. So these are all subtopics. ABG is a subtopic, decay is a subtopic, your purpura fulminans, meningococcal meningitis. These are all small case scenarios you have to be aware of for your CBS. A 70-year-old male is presenting to the ICU with community acquired pneumonia after 7 days of antibiotic therapy with piptaz and clindamycin. He's having severe abdominal pain with diarrhea. Okay. So he's having generalized tenderness also. Abdomen is in the right iliac. Then they got the X-ray which shows this. So what is the diagnosis here?
Toxic
Toxic
Megacolon.
megacolon with
Due to
thumbprinting sign.
Yeah, correct. So what is it? Why does this patient have toxic megacolon?
patient has got clindamycin.
Probably C. difficile infection.
Yeah, so probably the antibiotic, the signal, right? The antibiotics the patient was on. So what are the common antibiotics which cause this kind of thing, C. diff infection?
clindamycin,
Clindamycin.
fluoroquinolones.
Cephalosporins.
Yeah, fluoroquinolones,
Fluoroquinolones,
penicillin antibiotics.
Correct. Okay, very good. Then what? How do you manage toxic mega? So for how do you manage C. diff first? You can tell, and then you can tell how do you manage your the toxic megacolon.
oral vancomycin.
Yes, very good. So basically, depending on the severity of the infection, isn't it? Yeah.
Yes.
How do you specifically diagnose this thing? Specifically diagnose C. diff toxin infection?
A stool test with Clostridium difficile.
Pleural dehydrogenase.
Stool PCR for C. diff toxin is the most common one, and glutarate dehydrogenase is the second one. Correct. Both are correct. If you say both, also it is enough. If you say one of them, also it is correct. Okay. So, what are the complications you can expect from C. diff infection?
Perforation,
Yeah.
Shock with multi-organ.
peritonitis,
Okay. So, one is toxic megacolon. What else?
Perforation, sepsis with multi-organ dysfunction.
Yes, sepsis with multi-organ dysfunction. Correct. Okay. So, what are the features of severe C. diff infection?
Leukocytosis, septic shock,
Correct.
uh,
High fever, acute abdomen, peritonitis, features of ileus, bowel obstruction, high lactate, and in imaging you can see this kind of distended bowel. Correct. How do you manage mild C. diff infection? Mild to moderate.
mild to moderate is with the oral vancomycin and fidaxomicin.
Okay.
And hydration.
So how do you manage a second recurrence of C. diff infection? So the first recurrence is always managed as the first episode only. How do you manage the second recurrence?
If it
Fidaxomicin.
is less than 12 weeks, then you can give fidaxomicin if it was treated with vancomycin before orally.
Yes, very good, correct. And third recurrence?
stool transplantation,
High,
Yeah, fecal
higher dose
microbiota.
of
Tissue transplant.
SLT.
microbiota.
So you have to answer according to the question. Like for instance, if it's a first recurrence, we treat it as a first episode always. If it is a second recurrence, we actually try fidaxomicin if vancomycin has been tried. If it is a third recurrence, then we do fecal microbiota transplant. Okay, complicated, severe C. diff. How do you manage?
Colectomy, total colectomy.
Increase the dose of the vancomycin, giving
Yeah.
IV flagyl,
So what is the
rectal
maximum dose of
vancomycin,
vancomycin we can go up to?
500 Q6
500 mg
hours.
6th
Yes,
hourly.
correct. 500 QID you can give. Very good. Okay.
Yes,
Plus you can give this.
with
Yeah.
rectal vancomycin if there is ileus.
Very good. So you can also give vancomycin enema in case of ileus. And also, if it doesn't respond to all this, we have to consider surgery. Very good. You guys
Role
are very well prepared. Okay, next.
of intravenous metrogyl, madam.
Yeah, so oral vancomycin plus intravenous metronidazole. So oral vancomycin, you can increase the dose, and vancomycin enema if there is ileus, and surgery if it doesn't respond to all these things. If you answer in this structured way, I think the examiner will be satisfied. Okay, next question. What is there in this ECG? This patient is present to you with palpitations and giddiness, and GCS is 15, heart rate is 190, BP is 75 by 50. So what is this?
Ventricular tachycardia.
Okay. How do you manage this patient? This patient is in shock.
Cardioversion.
Yeah. Okay. What is the joules you want to start with, and how do you go up?
100.
200 joules. Biphasic 200 joules.
You start with 200?
Start with 100, madam.
Okay.
100.
And
Then we will increase.
okay. Any other this thing therapy, the drug therapy you would want to try here?
Try amiodarone, but
Okay.
the size has got hypotension.
Okay. Correct. So this is one of the ECGs. We'll go to the next question. Yeah. 55-year-old woman is present to you with excruciating chest pain worsening over recent days. And this is your ECG, which is showing extreme tachycardia. What is this?
This is
Correct.
it is
You're right. You're
it
right.
is
What is it called?
it's a
So it is deep point.
it
Yes.
is a wrong. We have to
Torsade
check the leads.
pointus. Yeah. Okay. What is that? What is exactly torsade pointus?
Polymorphic.
Polymorphic VT. Correct. So what are the risk factors of that developing?
Hypomagnesemia.
Yeah, that is
Long
one.
QT
What else?
interval.
Yeah,
Prolonged
prolonged
QT
QT
interval.
interval. So what are the drugs which are causing prolonged QT interval in your ICU? Can you name 5 drugs which cause prolonged QT interval?
Amiodarone.
Proton pump
What are the
inhibitors,
common ones first which
antipsychotics.
actually you use and you need to monitor your QT interval daily and
Macrolides, madam.
yeah, okay. So first you can talk about the antibiotics, the various antibiotics which actually cause long QT syndrome. So not syndrome, sorry, can cause prolonged QT interval. So what are the antibiotics you know of?
Antihistamine.
Cepro.
Sorry?
Macrolides.
So macrolides are
Azithromycin.
definitely there. Your azithromycin, clarithromycin, all this can cause. Any other antibiotic you know of?
Fluoroquinolone.
Yes,
Quinolone.
very good. Levofloxacin can definitely cause. What else? Moxifloxacin,
Quinine.
levofloxacin.
Antiviral also.
Okay. Any antifungal you know of?
Ketoconazole, madam.
Sorry?
Ketoconazole. Fluconazole.
Okay, but more common than that. More common than that.
Fluconazole.
Fluconazole, right? Yes, fluconazole, correct. So apart from that, as you said, amiodarone definitely causes haloperidol. So you have to talk about antipsychotics also because we tend to forget that what we do is we prescribe these macrolides, fluoroquinolones with the antipsychotic to our elderly patient, and we forget to measure the QTC every alternate day, and these patients land up in trouble. So definitely you have to talk about your antipsychotic drugs like your haloperidol causes prolonged QT interval. Everybody knows that,
Butabine.
right? Yes. Correct. Ziprasidone and also all these atypical antipsychotics definitely cause prolonged QT interval. So, and they are at high risk to cause prolonged QT interval. So, up to date, if you open that, so there is a chart which actually tells that you have high risk medication, moderate risk medication, and low risk medication. So, try to remember some of the high risk medications. Another quetiapine also causes, as somebody said. Another very interesting thing, especially for my Indian friends and students who have joined today, your anti-malarials. Right, so you have to be careful about the quinine which you are prescribing for your patient. Also, that also cause prolonged QT interval. So, okay. So apart from that, there are a lot of low risk drugs we are not concerned about. So, how do you manage this patient? This patient is coming to you with torsades. What do you do?
Magnesium
If the
sulfate.
patient is
Magnesium.
Yeah,
magnesium.
correct. So if the
If
patient is
it's
actually present with symptomatic bradyarrhythmias, what will you do? So symptomatic,
stable
right?
or unstable,
Yeah. So if it is unstable, what will you do? And if it's stable, what will you do?
pacing and
stable we give magnesium sulfate. If it's
Magnesium.
unstable, we cardiovert.
Yeah. Okay. We have to give shock. Correct. So next question again is on ECG only. So a middle-aged patient is present to you with chest pain and diaphoresis. The blood pressure is dropped to actually 80/50 following sublingual nitrates. What is the reason for that?
This is
Uh,
showing
Ventricular infarct. Yeah.
in inferior wall,
Yeah.
and ST elevation lead 3 is more than lead 2. So probably there is a right ventricular involvement also.
Correct. That is the reason for your blood pressure drop on giving sublingual. So you cannot give sublingual nitrate in those patients. So what is the management?
Oxygen,
urgent PCI.
Right-sided ECG.
oxygen, and
Fluids and
pain.
PCI.
Yes, correct. Very good. So fluids you have to give. You cannot give listen. So what is the percentage of RV infarction in your inferior STEMI? Any idea?
40 to
40%.
45.
Yeah, that's good number. Actually, 40% of your inferior MI gets complicated with RV infection. So these patients are extremely preload sensitive, and due to poor RV contractibility. Just one second. Yeah. So basically, the thing is that these patients are extremely preload sensitive due to poor RV contractibility, and they develop severe hypotension in response to nitrates or other preload reducing agents. And this hypotension can only be managed by giving fluid loading, and nitrates will be contraindicated. Correct. Okay, so we'll move to the next question. Which conditions are shown in this kind of capnograph?
Esophageal intubation.
Is yeah.
Yeah.
Esophageal intubation.
Yes. Anything else?
Disconnection.
Yeah, probably
Disconnection.
disconnection or esophageal intubation. That is correct. Okay. So I'd like to stop the CBS here. Anything else you guys want to ask? These were my 10 questions of my CBS.
Madam, for an ABG, like you said, we have to tell the primary problem, but is it necessary for us to calculate the gap ratio and tell that metabolic
No,
alkalosis as
no,
well?
no, absolutely not. So please tell only in CBS, especially, no, you have to only ask like how answer whatever is asked. That's all. There is no doubt
Okay.
about that. So if they ask you what type of disorder you see, you just tell that ki I see high anion gap metabolic acidosis. That's all. Then they will ask you the further question that what is the other problem here and all that. Then you slowly answer. Don't jump into your answers and tell anything extra what is asked in CBS, because there are 7 steps of analyzing one ABG, starting with the validity, right? So first you have to do
Yes.
the validity testing, then you have to know the primary disorder, then you have to know what kind of compensation is occurring, then you have to calculate if the compensation is adequate, then you have to go into the anion gap, then you have to go into the gaps. So these are the 7 steps. So, but you have to only answer what is asked. Because in the CCS, still you can go a bit deeper, but in CBS, you have to be very careful that you only answer what is asked, because unnecessarily, then they will not be able to finish their thing on time,
Okay.
right? Yeah. Okay. So now I'll share my CCS screen with you. We are running a little late, but I wanted to do this discussion in a bit of detail so that everybody is helped. There's no point in running. Yeah. Okay. So basically, this is my CCS case, but this is not the same CCS case I discussed with the 3 candidates a few days back. But this is a very important one which I made, because that was one an ARDS one, and I think ARDS will be discussed in the subsequent one. So this is the one. This is about antimicrobials and sepsis. A 72-year-old male is presenting 60 kgs and presenting to the ED with abdominal pain, and his past medical history is hypertension and previous heavy alcohol intake. On examination, these are the findings. He is febrile, he is drowsy, he is confused, his peripheries are cold, he is hypotensive, tachycardic, tachypnic, and the saturation is 95% on 6 liters. Abdomen is tense and tender. You start immediate fluid resuscitation with 30 ml per kg, then NORAD is started. CT shows abdomen has extraluminal gas and suspected extraluminal fecal content with a perforated sigmoid colon. And this is your ABG. These are your labs. So what happens is that patient is treated with IV antibiotics, taken to the operating room. During the procedure, there is fecal peritonitis, perforated sigmoid colon. You resect the sigmoid colon, you do a Hartmann's procedure, and then shift it to your ICU with a center line and art line in place. I'll give you 2 minutes to go through this, and then we will ask the questions. Okay, so we'll go to the questions. Can anyone summarize the case for me, please? Yeah, it's not. It's a simple case which you see daily.
Yes, 72-year-old gentleman with background history of hypertension and alcohol abuse, who had come in with mainly altered sensorium and in shock, who underwent laparotomy for probable bowel perforation.
Correct. Okay. So, what is the diagnosis?
It shows normal anion gap metabolic acidosis with acute kidney injury,
So, you can't
probably
tell the
secondary to
diagnosis
intra-abdominal
about the
peristalsis.
finding, like a finding of ABG. Any, I don't think that's how we have to attempt the diagnosis. You say the diagnosis is septic
Septic
shock,
shock
Intra-abdominal
with
secondary to
hypotomatitis.
population peritonitis. Clear?
Mm.
Yeah. So septic shock secondary to perforation peritonitis is how we have to answer as the diagnosis. Okay. Um, what are the likely causes of his confusion and drowsy state?
Hypotension, hypoxia,
Yes,
Hypotension, sepsis.
septic
correct.
encephalopathy.
Correct. How do you define septic shock?
If there is
Shock is requirement of vasopressors to keep a map of more than 65.
Correct. Okay. So basically, you can what you can tell is sepsis is a dysregulated host response to an infection, and if it is associated with shock with a MAP less than 65, causing cellular and circulatory dysfunction, that is called a septic shock. So you can tell a little elaborate because sepsis we have to define properly and septic shock also. What therapy you can institute at this point of time, which is going to improve this patient's outcome?
optimization of his fluid status, starting
Mhm.
vasopressors early,
Mhm.
and antibiotics.
Very
And
good. So as we discussed the bundle, yeah, what else? Sending
sending
culture.
it, sending culture.
Yeah. Okay.
And if the blood pressure not responding to noradrenaline, we can start vasopressin. If there is no response, we have to give stress steroid.
Yeah. Correct. And also source control. Please, everybody, whenever there is a source of sepsis, utter the word source control. Like what we are doing here. Peritonitis, we have to do exploratory laparotomy. How do you do the screening and initial resuscitation of this patient? Means if the patient is in ER, how do you know the patient is sick enough? How do you actually do the initial screening? What do you look for to know the patient needs ICU, and what do you do for the initial resuscitation of this patient?
We'll go through ABCD, airway, breathing, circulation, disability
Yes.
approachment.
Okay, you can answer like that definitely.
Lactate level also.
Lactate level.
Yeah. Shock state. So basically, depending on the clinical severity, the patient will require ICU admission. So what
SOFA score.
antimicrobials? Yeah. SOFA score is also, you can definitely talk about SOFA score. When will you deliver antimicrobials in this patient?
Preferably
According to
within first hour.
1 hour.
within first hour,
hour.
according to
Within
the
the first
survival
hour.
guidelines. Okay. On the arrival to ICU, this patient is still anesthetized, trachea is intubated, lungs are mechanically ventilated, BP is supported by NORAD. Patient is in operating room. Total 4 liters of fluid the patient has received, but the urine output is very low. This is your blood pressure. Your IVC you saw, IVC is extremely variable. This is your ABG. So, what are the signs of intravascular depletion in this patient?
Uh,
Lactate is
increased
high.
Cardia, decrease
increased capillary refill time, increased skin turgor, uh, elevated lactate levels,
tachycardia and
Less urine output, IVC variable.
significant stroke volume.
decrease urine output.
Pulse pressure is normal.
So, what are the signs of intravascular depletion?
Increase skin tugger, increase capillary refill time, reduced map, um, probably reduced urine output as well, and other objective variations, objective medicine, this thing like stroke volume variation, pulse pressure variations.
Correct.
But the pulse pressure is normal and CVP is also.
So here what you can see is,
Not
I'll tell you, CVP is normal, but you have the pulse pressure variation. They have clearly written marked respiratory variation.
Marked.
So which one will you rely more on, the static or the dynamic, measures of fluid responsiveness?
Variation.
Dynamic.
Yes, so the variation, the respiratory variation of the IVP is like more reliable compared to the CVP. Another thing is the urine output is also low. And probably you can say that I can check the IVC distensibility or index and find out if patient is going to respond to fluid. The lactate is also on the higher side. So you can talk about the dynamic measures of resuscitation which you use in deciding if the patient is responsive to fluid or not. After an assessment, the patient shows that they have inadequate intravascular volume. Which fluid resuscitation will you choose to be administered within next 30 minutes to 1 hour, and why? So what is your preference choice of fluid?
Crystalloids.
Crystalloids, correct.
Crystal.
So balanced salt solution you can say, or crystalloids you can say. Okay. And what are the different stages of fluid resuscitation, if anybody can tell me that?
resuscitation, optimization, stabilization, and evacuation.
Debriefing.
Evacuation. Yeah. So the ROSE protocol, everybody should read about. Correct. Now the patient is in ICU for an hour and still undergoing mechanical ventilation after receiving 1 liter of balanced solution and 500 ml of human albumin solution also. The MAP is still 62, heart rate is 105, urine output is 35 ml. Patient is given Piptas. Post-operatively, fentanyl infusion was given. 1 gram of IV acetaminophen is also given. So basically, you are giving NORAD support to support the blood pressure. Then after 24 hours, the patient is 2 liters fluid positive. Echocardiography is still normal. IVC is still normal. Patient is sedated, ventilated, and the current ventilatory settings are this: 450 ml, respiratory rate of 20, and this is your X-ray, and this is your ABG. So my question is, what monitoring strategies will you use to decide if you have to give further fluid or not? Does the
Where is
patient need
monitor?
more fluid? Does the patient need more NORAD or vasopressin? Or how do you decide that?
Pulse pressure
Where is
variation, stroke
Echo.
volume variation,
Clinically, if clinical judgment and as well as objective judgment, clinical judgment, if there is any kind of increase in FiO2 requirement, and we have given enough amount of fluid, and we can
Passive
start
leg
on
raise.
vasopressors. If there is any if there is any significant pulse pressure, if there is no pulse pressure variations, there's no stroke volume variation, passive leg raising test is negative, then probably we can think of starting vasopressors.
Okay. So passive leg raise test you all said, but do you do what cardiac output monitoring device you need? How do you actually tell if the PLR is positive or not?
there is
If
a
with the
The
passive
increase
leg
in
raising, if
stroke
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 volume
volume.
variation is more
cardiac
than
Very
12%,
Stroke,
less than 12%.
more than
stroke
10%
slow
volume
track.
increase in
variation
cardiac
change.
output.
How will you see a stroke volume variation without a cardiac output monitor?
Actually, we need a cardiac
Either with echo or flow track.
Stroke volume variation or
Echo
uh,
using
VTI.
VTI.
Yeah, so basically, that is the way of answering actually, that not everybody will be well versed in echo or not everybody will have a cardiac output monitor, right? So we have to give an option that, suppose we do a PLR, but will you do a PLR in a patient who is post-op abdomen case?
No.
No, so they don't give an answer in this case. But of course, PLR you can answer separately for any case of any patient who is in whom you want to see the fluid responsiveness. So all you have to say is that I will see that the cardiac output is increasing by 10%, or this, as you said, the stroke volume variation is more than 10% if I do a PLR. But for that, I need a cardiac output monitor in place, or I need to have the skills to do an aortic VTI. So these are the two things we have to know about. Okay. So, but in this case, what you can probably tell is that I can see the IVC distensibility index. I can do an aortic VTI to myself, see if there is, after giving a fluid bolus as a response or not. or I can rely on pulse pressure variations to decide if the patient is more responsive to fluid, or I have to increase the dose of vasopressors. So, what are the choices of vasopressors in case of refractory shock?
Noradrenaline followed by vasopressin.
Correct. And use of IV corticosteroids we have already discussed. What does this chest X-ray show?
Shows bilateral cardiophrenic
Bilateral
angle, costophenic angle blunting, probably
bilateral pleural
minimal
effusion.
pleural effusion
Some amount of pleural
with
effusion.
Possible, yeah, yes.
increased B lines in the bases of the lungs.
Yeah, so there is some
And
amount of fluid overload probably also. So if the patient's FiO2 requirement is uh, the PO2 is only 74 and FiO2 is already 60%, what kind of mode of ventilation should we use for these patients? What ventilatory strategies?
Lung protective.
Lung protective
lung protective.
ventilation with 6
Yeah,
to 8,
lung
6
protective
ml per
ventilatory
kg
strategies we have to
tidal
use.
volume.
Yeah. And what last question in this is, what are the recommended empirical antibiotic options we have to choose for complicated intra-abdominal infection?
Again, based on the local
Tetracycline.
antibiogram
Neutralizing
protocol,
antibiotics along with
gram
anaerobic cover and
Negative and gram.
So mainly gram-negative coverage also. So can you give me an example of the kind of antimicrobial coverage you will go for in this case?
Meropenem.
Plus teicoplanin
And
should be okay. Yeah.
if it is not improving, I will go after 3 to 4 days. We can go with an antifungal also.
Yeah, correct. So after 3 to 4 days of shock, which is not responding to broad spectrum antimicrobial, what about nutrition of this patient? Any plan you can give for the nutrition of this patient?
after 24 hours, we can start with the trickle feeds and for 5 days. If there is if the 50% of the nutritional needs are not met, then we can probably think of adding a parental nutrition to meet the needs within a week's time.
Okay. Yeah, so early enteral nutrition is definitely preferred, as Christina also said. So, but if patient is not responding to that, then we have to actually go for TPN after 7 days if the patient is not, depending on if the patient how the baseline nutritional status of the patient is. Okay, any doubts in the CCS case you have? So I think we covered extensively everything: sepsis, septic shock, intra-abdominal sepsis, then about the ventilatory settings in these patients. Then it went into hemodynamic. How do you decide if the patient is fluid responsive or not? And then nutrition also. Any doubts you guys have? Else we'll end the session here.
Thank you, everyone. You can leave.